we can go over those questions at the end of the presentation. So just to jump right into things. So this evening, we're going to talk about dementia-related behavior changes and strategies. So I just wanted to start with a quick land acknowledgement. The Alzheimer Society of Durham Region is located on the traditional homelands of Mississaugas of Scugog Island, First Nation, who are the stewards of the land. At this time, I'd like to invite participants to quietly reflect on the land they are on. The Mississaugas of Scugog Island First Nations are part of the Williams Treaty. As settlers old and new of this treaty land, we recognize the ways in which we are benefiting from the destruction of their relationship to land, family and community, and traditional practices and ways of life. Alzheimer Society of Durham Region recognizes the profound need for informed relationships with the Indigenous community. We acknowledge the injustices of the past and the continued legacy and impact of colonialism on the Indigenous community today. We are committed to building awareness and addressing existing challenges facing Indigenous peoples' access to care and support through staff education and consultation with the Indigenous community, and are working towards a better future for every Durham resident living with dementia and their care partners. So I think it's important, and I think you can all agree that we talk about some of the stats that sort of has brought us all here today and has piqued our interest. So in the Durham region alone, I'll just highlight some of the stats on the screen here for you. In the Durham region alone, there is estimated to be approximately 12,000 people living with dementia, just in the Durham region alone. And then flipping to the slide here, 500,000 people living with dementia in Canada, 76,000 people living or diagnosed each year in Canada, and approximately 912,000 Canadians predicted to be living with dementia by the year 2030. So 2030 is just around the corner. The numbers are staggering. And 1 in 5 persons experience being a care partner for a person living with dementia. So we've chatted about what's brought us all here today, and I think it's important that we go over the dementia umbrella just to give us all a little bit of information and knowledge when we hear the term dementia. So dementia is an umbrella term for any disease that causes changes in the brain that gets worse over time. So changes can include memory loss, problems with language, trouble with familiar tasks. Dementia is diagnosed when changes start to affect the person's everyday activities. So there is no test to diagnose specifically dementia. Instead, there's a variety of other conditions that are ruled out first, which we'll talk about in a minute. So changes experienced by the person depend on where the damage occurs in the brain. So people will experience dementia differently. I think that's very important to highlight. And we often say if you've met one person with dementia, you've met one person with dementia, because it's so different from one person to the next. There are many types of dementias. However, for today, we're just going to talk about the 4 most common. So we'll start with talking about Alzheimer's disease. Alzheimer's disease is the most common and accounts for approximately 60 to 80% of all dementias. The damage from the Alzheimer's disease starts in the hippocampus of the brain. So that's where we store memories, where we make memories, which is why short-term memory loss is an early symptom and slowly progresses to other regions of the brain. People living with dementia may not be able to tell you what they had for breakfast, or even what they had for, or even sorry, excuse me, or even if they had breakfast rather, but they can tell you every detail of a camping trip, let's say, that they experienced when they were at a young age. So under the age of 10, or, maybe 9, 8 years old. And that's because their short-term memory is impaired, and they're no longer able to retain those recent memories. So if you think about an onion, if you just sort of imagine an onion, and the outer layers of the onion are the most recent memories, and the inner core are the oldest memories. So with Alzheimer's disease, it sort of peels back the layers of the onion, leaving them with their first memories that they sort of stored years ago, which is why they can remember things that happened many, many years ago, but they can't necessarily remember things that happened a few hours ago. Vascular dementia is the next most common type, and it accounts for about 20% of all dementia diagnosis, and occurs when there is impaired blood flow to the brain. So such as a stroke or a mini stroke, depending on where the stroke occurs and which area of the brain is deprived of oxygen, will determine which cognitive loss occurs. So usually progresses in steps. There's a decline, and then there's a stabilization, and then there's a decline, and so on and so forth. Lewy bodies dementia is the third most common type, and it accounts for 5 to 15% of all diagnoses. So in Lewy bodies dementia, areas of the brain involved in movement and thinking are most affected. A person may experience symptoms similar to those of Parkinson's, such as that rigidity of muscles, maybe tremors in their hand, maybe that stooped posture, or that sort of shuffled movement, shuffled gait. Alzheimer's disease, such as memory loss, language, and reasoning. Lewy body dementia can occur by itself or together with Alzheimer's disease or Parkinson's disease. You often see a marked fluctuation in alertness. Memory difficulties may not be it may not be one of the early symptoms, however, but can develop as it progresses. One thing that is very common with Lewy bodies dementia is the experience of those visual hallucinations. So seeing things that aren't real. This seems to be quite common when it comes to Lewy bodies dementia, and an increase in their confusion. So the frontal temporal dementia is an umbrella term for a group of rare disorders that primarily affect the frontal and temporal lobe of the brain. The areas generally associated with our personality, behavior, emotions, language, speech, abstract thinking, and movement. In some cases, the brain cells in these areas can shrink and die, and in other cases, the brain cells in these areas get larger, containing round silver, what they call Pick's bodies, so like Pick's disease. In other situations, the changes in the brain often lead to changes in behavior and problems with speech in the early stages. And it's estimated that approximately 2 to 5% of all dementia cases are frontal temporal dementia, and frontal temporal dementia accounts for 20% of all dementias for those under the age of 65. These types of dementias can occur on their own or together, which is called mixed dementia. And what is similar in all cases is that there is no cure, and they are all progressive, meaning that they will get worse over time. Moving right along to the brain and Alzheimer's, I really like this picture. I think it really demonstrates a lot of great information. So the brain is one of the most vital organs that play a role in our every action and every thought. We use our brain in everything we do. We use it to breathe, we use it to eat, we use it to dress, we use it to walk, and so on and so forth. So when comparing the brains of two individuals, one with Alzheimer's disease and one who did not have the disease, who lived to be the same age, the same height and weight, as well as the same gender, there are significant differences in the two brains, I think we can all agree. So the brain of an Alzheimer's patient is considerably smaller to the brain in comparison to the healthy individual. So in fact, the brain shrinks down to as little as 1/3 its normal size as the disease progresses. Also, when we look at a healthy brain, the folds of the brain are very full and are closely packed together. In contrast, a brain of someone who suffers with Alzheimer's disease has folds that are much more narrow than a normal brain, and the gaps that are between the folds are significantly wider. So it's important to recognize that dementia is progressive and that symptoms will change and develop with time. There's no set path on how long someone will stay in a particular stage, as it's unique to every person. So the average progression is 8 to 12 years. It's known that capacity will decline with the progression of the disease, and activity will need to be adjusted or modified over time. So at the early stage, there's a mild impairment, and common symptoms are forgetfulness, communication difficulties, and changes in behavior. The middle stages bring a greater decline in the person's cognition and functionability. So memory and other cognitive abilities will continue to deteriorate, and they may require assistance with daily tasks such as shopping, housekeeping, dressing, bathing, et cetera, et cetera. In the late stages, the person eventually becomes unable to communicate verbally or look after themselves. So care is now required 24 hours a day. When the person nears death, comfort measures become the focus in all dimensions of physical, emotional, and spiritual needs. It's important to remember that every person is unique in their symptoms and progression. So I often say that what one person experiences living with dementia can be so different from what somebody else experiences, and it really depends on the changes in their brain and how their in particular dementia progresses. So what happens to one person isn't necessarily going to happen to another. All very unique, just as we all are. So there are 10 warning signs when it comes to Alzheimer's disease. So memory loss that affects the day-to-day abilities, forgetting things often or struggling to retain new information, or maybe they ask the same question multiple times, and that's because their brain is just no longer holding short-term memories or the information that has been given to them. They're just not holding that information. Difficulty performing familiar tasks, so forgetting how to do something that they've been doing their entire life, such as preparing a meal or getting dressed. Problems with language, and we'll get into that a little bit more later on in the presentation, but forgetting simple terms or simple words, or substituting words that don't fit the context. So the person may say, "Where's my cold?" But what they really mean is, "Where's my sweater?" because they're cold. Disorientation in time and space, so not knowing what day of the week it is or getting lost in a familiar place. Maybe the person is talking about their parents as if they were still alive. That's because in that moment, they are in a very different time. Or maybe they've always walked the same route in the neighborhood, or now they're getting lost. Impaired judgment, so not recognizing a medical problem that needs attention, or maybe they're wearing light clothing on a cold day. Problems with abstract thinking, so having difficulty balancing a checkbook or not understanding what numbers are and how they're used. And misplacing things in unusual places. So putting things in strange places, like a dress in the fridge or a wristband in a sugar bowl. Changes in mood and behavior. So maybe they're presenting with severe mood swings from being easygoing to now very quick-tempered. 1 minute they are laughing and the next minute they are crying, or they're angry for what seems to be no apparent reason. Changes in personality, so acting out of character, confused, suspicious, or even fearful. Loss of initiative, so losing the interest in friends, family, or favorite activity. Maybe the person used to attend church every Sunday and now they're no longer interested. So some of the cognitive losses, so we sort of package it up into the 8 A's of dementia, so to speak. So the 8 A's of dementia are one of the ways of understanding how dementia affects the brain. So each of these represent damage to a particular part of the brain. So the type and stage of dementia will affect which losses are experienced and their severity. So let's jump right into what we're looking at on the screen, and starting from the top. Amnesia. So amnesia is the loss of memory. So at first, short-term memory will be lost, and eventually long-term memory will also be affected. A person with short-term memory loss may not remember what was just said, or and that is why they'll often have those repetitive questions or make those repetitive statements. Aphasia is that loss of language, and it can include both speaking and understanding others. So the person may have trouble thinking of the word that they would like to use, or they may mix up words, often referred to as a word salad, or difficulty understanding what other people may be saying. So it often leads to misunderstandings. They may say fork when what they really mean is spoon, just another example. Oops. Moving right along. Agnosia is that loss of recognition to familiar sensory information. So an example would be people with agnosia are not able to sort out what they see or hear, maybe. They may not recognize family members or friends or even themselves in the mirror. So safety can be an issue here if the person sees an object but can no longer recognize what it is. The handle of a toothbrush or a razor can look similar, and that is a huge safety risk. I think we can all agree. If you imagine where a razor might be kept and where a toothbrush might be kept, that's what seems familiar environmentally, but the use of those items can be confusing and can certainly increase the risk factor. Apraxia is that loss of ability to initiate purposeful movements and patterns of movement. So people with apraxia have trouble understanding directions, back, front, left, right, up, down, and so on and so forth. They may have difficulty controlling their body parts, like brushing their teeth or getting dressed. They know what they want to do, but for some reason, the message doesn't sort of compute between their brain and their muscles. Here's a funny word for you. Anosognosia is that loss of ability to recognize there is anything wrong. So the person is not pretending or in denial. They don't realize that there's a problem. And that's because the part of the brain that allows one to reason is now damaged. So this can cause challenges when the person resents being told what to do or what not to do, because they don't know what they don't know. Altered perception is that misinterpretation of sensory information, which may lead to illusions or misperceptions. This can be upsetting for both the person and their care partners. So other perceptual loss is the loss of depth perception. So the ability to see in 3 dimension, it becomes difficult for the person to judge high from low, or deep, high, deep, long, wide, near, far, and so on and so forth. A person may be afraid to get into a bathtub because when they look at the bathtub, they have no ability to see how deep it is. So that can be upsetting to the person. Moving right along to apathy. Apathy is when an individual appears unmotivated or uninterested in activities. So the person with apathy experiences a loss of drive, or they just lack that initiative. So the part of the brain that controls initiative of activity is damaged to the point where it may not occur to the person to do anything at all. So they may appear to be completely happy to be sitting in a chair in their room all afternoon, but really they're just lacking that ability. They're struggling with apathy, and they're just lacking that ability to initiate activity. Attention deficit can include the loss of ability to maintain attention or loss of ability to shift attention. So this means the person may be easily distracted and unable to stay on task, or getting stuck in a repetitive action or idea. For example, they may get up from the table before finishing a meal, even though they're hungry, or they may fold and unfold a napkin over and over and over again. Moving right along to dementia risk factors. So risk factors are aspects of lifestyle, environment, genetics, genetic background that contributes to the likelihood of getting a disease. So risk factors on their own are not the cause of the disease. Risk factors represent an increased chance, but not a certainty. So similarly, having little or no exposure to known risk factors doesn't necessarily protect a person from developing a disease. Non-modifiable risk factors are the things that we cannot change. Our genetic, our medical history, such as Parkinson's or liver disease, and gender. And we can note that women make up for 2/3 of all cases of dementia. Modifiable risk factors are within our control. So things like high cholesterol levels in our blood, high blood pressure, diabetes, smoking, obesity are some of the major modifiable risk factors for cardiovascular disease. So including heart disease and stroke. The risk factors for cardiovascular disease represent risk factors for both Alzheimer's disease and vascular disease. These cardiovascular risk factors are more common as we age as well. I think it's important to note. There's been a lot of research done recently on the link between hearing loss and dementia. So hearing loss can significantly increase one's risk of developing dementia. And basically what we say is what's good for your heart is good for your brain. So we're going to go over some of the treatable conditions. I'll just pop them all up on the screen here. Whoops. Treatable conditions. So there are many conditions that can create a temporary dementia or reversible dementia, quote unquote. These treatable conditions can be reversed or cured, and the brain can regain lost functions when treated. However, this is not possible with dementia, so not to be confused with dementia. So depression can mimic dementia with symptoms such as mood changes, personality changes, apathy, loss of ambition, social isolation, et cetera, et cetera. Infections or delirium can cause severe dementia-like symptoms in a very short period of time. So we're talking within hours and days, often seen in untreated urinary tract infections, which we like to give the example as we get older and perhaps as our mobility changes, we might see people decreasing the amount of fluids that they take in the afternoon out of fear that they're going to have to get up to go to the restroom during the night and disrupt their sleep, et cetera, et cetera. But that also puts them at risk for dehydration and subsequently puts them at risk for the urinary tract infections that can present with dementia-like symptoms. And it is a medical emergency. If there's an infection in your body, it's important to seek medical attention right away. Moving right along to medication side effects. The side effects of some medications not taken properly or taken too many can cause temporary dementia-like symptoms. Metabolic disorders such as liver disease, diabetes, dehydration. Again, like we talked about earlier, that hearing loss and also vision impairment, left untreated, can cause increased confusion and disorientation. Sleep disorders. So sleep is imperative to our physical and mental well-being. Sleep deprivation, insomnia, sleep apnea. Nutritional disorders such as dietary or vitamin deficiencies can cause dementia-like symptoms. And other such traumas due to falls or confusion, tumors, thyroid, et cetera, et cetera. So it's important to talk about the preserved abilities. So when we are working with someone who is living with dementia, focus on the preserved abilities, the strengths, the past interests. Never lose sight of who the person is. So is their sense of humor still intact? Their long-term memory, primary motor ability, sociability and social skills, emotional awareness, use of senses, music appreciation. I can give you countless examples of where music has been so powerful with people living with dementia. It brings them back to a different time. And I often share the example of a woman who was in the late stages of dementia, and she had primarily been nonverbal for a very long time. And there was Amazing Grace playing one day, and all of a sudden she perked up and started singing Amazing Grace, and she even cried. You could see tears coming down her face. So that's just one example of how powerful music can truly be. Behavior changes. So to understand behavior change, we first need to understand that significant changes happen in the brain throughout the progression of dementia. When a person has dementia, the disease progress occurring in their brain can affect various lobes within their brain. When these lobes are damaged or they experience shrinkage, which we refer to atrophy, we also see resulting changes in abilities or functions that those particular parts of the brain are responsible for. And as a result of the brain damage, a person living with dementia can experience a variety of changes, such as physical, emotional, mental, and cognitive, as well as behavioral changes. In the past, these behaviors have been referred to challenging behaviors, as they can be challenging for the care partner, there is no doubt. But we're moving away from this, and now we call them responsive behaviors or personal expressions, as it's person-centered. Those terms are more person-centered and respectful language. The expression that people demonstrate are a response to something. So usually it's an unmet need. It isn't that a person living with dementia is choosing to be difficult or challenging. It's their way of expressing what is happening in their own brain. So often we hear the term again, responsive behaviors, when we're referring to those expressions and for those individuals who are living with dementia. The disease progress, or the progression of the disease rather, sorry, again, can affect what we mentioned before in the earlier slide, is that physical, emotional, mental, and behavioral changes. So just looking at the slide here, some of the unmet needs that we're sort of trying to play detective, trying to figure out what's causing the agitation, and trying to focus on what that unmet need is. So do they need to use the restroom? Are they hungry? Are they thirsty? Are they just bored? So being mindful and trying to play detective of what those needs may be. A few important points to consider and remember about a person living with dementia. The person is not doing it on purpose to make us mad or to push our buttons. The behaviors we are seeing are a result of changes in the brain. So when we see something strange or different or unnerving happening, always take a step back and try to remember that it is the brain. They're doing the best they can. They're not trying to be difficult again, and it's not the person's fault. It's they're responding and behaving the best way they possibly can based on their brain function. So I know it's easier said than done, but trying not to take it personally, which can sometimes, again, be easier said than done. The person living with dementia would not want to hurt you for the world, and it's easy to take it personally, but remember, they may be acting out of frustration, a fear, and trying to revert back to there's an unmet need and trying to be that detective. They're still human, and many of their actions are human behaviors, and we all act out on what our brain is telling us. A person living with dementia's brain may be telling them something different, and their reality may be very different from ours. And I often use the comparison to if everybody on this Zoom call, if we all attended the same wedding, and my perception of that wedding was the bride looked beautiful, the flowers were stunning, the food was great, the sun was shining. So that was my reality, my perception of the wedding. But if we all gave a response to what we thought of that same wedding, do you think that we would all have the same opinion? Do you think that we would all think the same way about the flowers, the food, the dress? You know, we all have our very different, and it doesn't mean that one of us is right or wrong. It just means that our perception of the world is different, and our perception of reality might be different. So a person who's living with dementia, they have their own way of processing the information that they're experiencing. So the person is still there. Keep the person at the center of everything you do with them, and treat them with respect and understanding. The disease doesn't define them. It's easy to get caught up in the losses that a person living with dementia may experience as their brain continues to change, but trying to identify their strengths that remain and focus on what they can do. For example, a person living with dementia may not be able to, say, button up their shirt, but they can still put their shirt on. So just trying to come up with different ways to sort of modify some of their remaining abilities. Focus on the positives. It can be really difficult to see the positives when so much is changing, but staying positive helps us stay motivated on this as our caregiving journey. So when we focus on the positives, it can help reduce stress and find ways to help the person who's living with dementia live well. So the person living with dementia may have difficulty with language, including difficulty with finding a word, or they may create a new word for the ones that they have forgotten. So they may also repeat a word or a phrase, have difficulty organizing words in their logical sentence, into a logical sentence rather. They may curse or use offensive language or revert back to their first language. Or sometimes they withdraw and talk less than usual, and often because they can't follow along in a conversation. So some of the simple steps to good communication, sometimes easier said than done, but try your best to remain calm and have a calm approach. Try to slow down and take your time. Get their attention and maintaining eye contact. This will help them with recognizing that you are speaking with them. And keep it simple. If you're trying to communicate with a person living with dementia, or trying to help them with completing a task, offer step-by-step instructions, one at a time, instead of saying, okay, Betty, let's get up and get dressed and put your shoes on, and et cetera, et cetera. Oops, my slide just slipped by there. Try to instead offer just one step at a time. So, okay, Betty, let's get up. And once she gets up, then, okay, once that task is completed, let's get dressed, and so on and so forth. So trying to break down each task that you're supporting the person through, as opposed to just sort of firing off a multitude of tasks that you plan on completing. Use gestures and visual aids. So if you're talking about getting dressed, consider holding a piece of clothing. Or if you're talking about brushing your teeth, you can make that motion. Watch and listen. It's not always about what's being said. Keep an eye on their body language. So if we say that 10% of our communication is verbal communication and 90% is nonverbal communication, you can appreciate why it's so important to be mindful of a person's body language. Trying to remain positive and reassuring. So give compliments or positive feedback. Reassure them if they're feeling unsafe. Remind them that you're here to help. Compassionate approaches. So some things in terms of your approach. So some things to consider is trying to reduce distraction. So being mindful if the TV is on or if there's music playing so that the person can focus their attention on the information you're trying to give. Be patient, cheerful, and reassuring. If you're doing care, tell the person what you're doing, what you're trying to do in the sequence. So step by step, what it is that you'll be assisting them with. Same as when you go to push someone in a wheelchair, be in front of them first so that they can see you, and then let them know when you're about to push them. Otherwise, imagine how startling that could be to all of a sudden have someone be in motion, have someone behind you pushing you forward. Give short explanation and instruction one at a time. Allow time for the comprehension and response. So if you have to repeat yourself, try to use the same words. Otherwise, the person's brain will now be trying to comprehend two different messages. So that can be overwhelming and overstimulating. And go with the flow. So it's nice that it's nice to always have a plan. It's certainly nice to have a plan, but honestly, if the plan isn't going so smoothly, just go with the flow, enter their world, I like to say, and go with the flow. And we often say at the Alzheimer Society to connect versus correcting. So connect, don't correct. Our truth is not necessarily their truth. So try not to argue with them, try not to confront them or insist, or try not to reason with the person. You will likely experience a person living with dementia will tell you that they are waiting for their mother or father. We don't need to correct them and tell them that their parent is no longer with us. But instead, we want to live in their world. We may say, tell me about your parents, or provide reassurance that their parents will be there soon, and provide a distraction. Because often if they're looking for something, it can often be that emotion. They're missing out on that emotional connection, especially when it's in reference to loved ones. So living well with dementia. So this is Ron. So at the age of 75, Ron was diagnosed with Alzheimer's disease. After Ron was diagnosed, he started to learn French and Spanish, but felt that wasn't enough. So at the age of 80, Ron enrolled in a full-time political science program at Wilfrid Laurier University. Ron says, I'm learning all kinds of new things at 80 years old. You can teach an old dog new tricks. So this is just another example, like we saw at the beginning with, pictures of those icons, that people living with dementia can still live well. So supporting the person living with dementia. So maybe your spouse, maybe a parent, family member, friend, neighbors, but regardless of who it is, we always want to remember that they are people too, and we should always treat others how we would want to be treated ourselves. So trying to be patient, remembering again that it's not their fault, remembering that it's, they're doing the best they can. Sometimes it takes the person living with dementia longer to process. So be sure to give them that time to answer. If you have to repeat a question or a comment, say it the same way. Changing up the wording can cause confusion and frustration. And really, truly avoid saying, don't you remember, or correcting people if they have said the wrong thing. So many people living with dementia have difficulty with word finding, and many mix up the message. So they may say, I'm waiting for my mother, when they really mean they're waiting for their wife. It's best not to correct them, as this can truly cause frustration. It's best to just go with the flow and live in their world. So give the person living with dementia choice instead of saying, what do you want to do? Or do you want to go for a walk or play a game? It's best to try to incorporate them in as much decision making as you can. And maybe even asking open-ended questions can be overwhelming to the person. So giving them choice, giving them simple choices. So for example, if you know that the person living with dementia typically has 2 different items for breakfast. So they are either going to have cereal or they're going to have a muffin. So rather than offering them scrambled eggs, just offer them the 2 options that they're typically going to go for, just to avoid that feeling of being overwhelmed. So I always like to make a point of mentioning before we conclude any of our presentations of all of the wonderful support, and it's on the screen here, that the Alzheimer's Society can offer. So there's lots of other ways that the Alzheimer's Society can help, not just with providing education. So the Alzheimer's Society has lots of great programs and services, most of which are free. And so again, beyond the education, but we do provide education on a variety of topics. So, and we also provide support for those who call our First Link program and speak to a system navigator. You can share your story and they can sort of go through what might work best for you. So whether that's one-on-one sessions, whether that's group sessions, whether that's in person or on the phone or via Zoom. So lots of different options. We also have a young onset adult day program and other recreational programs for people living with dementia. And our services are available in French and English. And we also offer respite programs for those individuals who are attending the Care Partners programs. And lastly, we also have a memory clinic. Memory clinics are spread out through Durham and Scarborough. So we do have Oshawa, Bowmanville, and Scarborough locations. And then one last plug for our annual Walk for Alzheimer's. So our annual Walk for Alzheimer's is coming up on May the 27th. So if you're interested in putting a team in, check out our website on how to register. And now we are open to questions. That concludes my presentation.